Excited to be here with this knowledge graph community. I consider this place my people. Uh, and I'm really excited to be here to be talking to knowledge graph enthusiasts at a time of such, I think, unparalleled change. And I love coming after this invited speaker um, because I'm going to leverage some of your lessons in this talk. So the talk is about facilitating reuse of mental health questionnaires via knowledge graphs. Um, and that's actually a little bit more of the local problem, but I'm going to paint the big picture that came from a triggering event. I'm using his language. So this is joint work with a number of people. It's joint work with Enrique Santos, who is a knowledge graph researcher, Kelsey Rook, who's one of my PhD students in computer science, Paulo Pinheiro, who's basically a knowledge infrastructure architect and also has worked with me on and off for 25 years. But he's now actually at Semantica, which is a company that he founded in Portugal to do knowledge graph stuff. Dan Gruen, who's basically a human-computer interactions guy, but also a consultant in my group. Bruce Trapita, who's a psychologist at UCLA, and he was the triggering event when he came to my office at RPI, where he's got a son in school, and he said, mental health, he didn't use these words, but mental health is kind of messed up. That was my interpretation of what he said. The fact that clinicians almost rarely use the best evidence-based interventions when somebody presents with a mental health disorder that has been measured by, approved vehicles. It's a disaster that this is not happening. So the triggering event for me was, I think he and I and the big group could change the world. Mental health is, a growing problem, and he's an expert on a number of portions of mental health, but particularly anxiety and depression. And he proposed to me that, or we collectively said, well, what if we did some knowledge graph and ontology around measurements for anxiety and depression, given that he's an expert in it, and then presented people with evidence for interventions that actually work. And so I'm like, wow, this triggered me to say, I think we could change the world in a short period of time. And the world really needs it. And the technologies that we're experts in can really make a difference. I'm going to talk today more about a local problem in that these questionnaires that you evaluate mental health issues are not really interoperable, and there's a lot of versions of them, and there's no one convenient place where you can go get everything. So I'm going to talk about more of the local problem, but I wanted to paint the big picture, and we will move from there. So I've really grown to love the National Academies of Sciences. They convened this panel on ontologies and behavioral sciences. Um, actually, I got to move over a little bit so I can read this. So it's an ad hoc committee for the National Academies of Sciences, Engineering, and Medicine. They gathered, reviewed, and discussed the literature development of ontologies in the behavioral sciences. And they had a mission: analyze the literature, synthesize the advantages and obstacles, identify recommended approaches to building behavioral ontologies, draw conclusions, and provide recommendations for improving behavioral ontology advancement. So I actually wasn't on this panel, but I did give a talk at this meeting, and there's a book that actually I think is pretty good. Bruce was on this, and it was, one of the quotes from the study was, inconsistent use of terms and classification systems makes it challenging to integrate findings and build bodies of knowledge, even in the domains that are constantly studied. The gap between what is known and the capacity to act on the knowledge has never been larger and continues to grow. That's a perfect statement for this group, for our technology. And Bruce said, hey, we need to know more about this stuff. So I've got the committee members up here because I thought it was kind of interesting that despite the fact that Mark Muson's title here is Center for Biomedical Informatics Research at Stanford, he's the only like really ontology guy on this whole panel. The panel is mostly, and there's one informatics person, Katie Borner, but the panel is mostly psychologists, medical people, primary care. So it's like really, it's a broad community. Um, but because I gave a talk on ontologies, like 4 or 5 people from this panel reached out to me and said, "Hey, this is kind of well, first of all, the National Academies of Sciences realized that they wanted to be able to integrate the content, and ontologies were kind of the best silver bullet that anybody is aware of, including me. And a number of the people who are really trying to make a difference in medicine and mental health said, without something like this, we're not going to get there. And it was sponsored by a wide range of organizations. I hope they all put the 5% away to do continued funding. I don't really know that for a fact, but there are calls. And actually, there was one NIH guy over there. I'm not sure where the pending call is coming from. I think it's from NIMH, the mental health group. But there's a pending call that's like all relatively far up there. I don't know that I've got the right literature or the vocabulary for ontologies to make a difference in mental health. So mental health and lots of medicine uses these screening questionnaires. And they're the most common instruments for screening patients. They basically have natural language questions that can be answered and then scored to determine the probabilities of associated disorder and diagnosis. And in order to get treated, you have to go through one of these questionnaires and you use these scales. And then this is the way you get insurance companies to pay for your interventions. So they're organized in scales. They can have a single scale or they can have multiple scales. And the colleague that we're collaborating with is one of the um, actually, I think he's the primary pusher or inventor of RCADS, the Revised Child Anxiety and Depression Scale. But he's also integrated with some of these other scales. But there's a bunch of them. And by the way, there's a lot of versions of all of them. And they're designed to assess specific symptoms. So here are a couple. The one on the left is the Patient Health Questionnaire, and it's a 9-question version. And then there's a Generalized Anxiety depression scale that's a 7-question version, and there's a 47-question version. And when you deploy in different countries, sometimes you have to eliminate questions about, say, sexual orientation can't be asked in certain countries, or use of certain drugs can't be asked in certain countries. So there's a lot of different versions of them. And then also people want to modify the scales and want to modify the answers. So it becomes relatively hard to put them together. But this is the way the science is done currently. And you can kind of game them also, which is another challenge, but we'll leave that for another time. So we're working with this revised Children's Anxiety and Depression Scale, RCADS. The most blessed or the most reused version, I think, is this 47-item youth self-report questionnaire. Self-report is always tricky, but that's what it is. There's subscales related to anxiety disorder, social phobia, generalized anxiety disorder, panic disorder, obsessive compulsive disorder, and major depressive disorder. And there's composite scales. And then they're rated on a 4-point Likert scale to come between never to always. And then there's parent versions, there's child versions, there's 19 different languages. When Bruce came to visit, he got a text from somebody saying, "Oh, we really need that Norwegian one. Please get it up there." So poor Bruce, he tried to give it away, but that created challenges. He tried to get funding for it, and he got initial funding. I'm looking at the NIH guy. There might be other NIH people. Thank you very much. But trying to keep it continuously funded is always tricky. And then he ended up forming a company that will show up later in the acknowledgments, because that was the way he could funnel some funding to help with these, all the different translations and all the different requirements once you go to reuse everywhere, because this scale is mandated in a lot of countries. I think at least in these 19, the countries that have those 19 languages, if you want to have your disorder reimbursed by insurance, you have to use these scales. But yet, you got to interoperate with them, which is not so easy. So, you can take your own scale. Actually, when we had our kickoff meeting, we all took this. I worry about things. I feel sadder. Oh, and actually, in the last 2 weeks, so it doesn't show it here, but at the top it says, in the last 2 weeks, these things are true. Um, and this is a child anxiety scale. So I would feel afraid on being on my own at home, might be different in a child setting versus an adult setting, or, depending upon where your home is. Um, so you answer these, and then there's a scaling, an analysis that helps us rank them. But there's lots of challenges. I also like that quote from Einstein, in difficulty comes opportunities, or something like that. So yeah, there's lots of challenges. We've got job security. So the architecture is based on these textual documents representing questionnaires. There's limited knowledge about that creation, what the assumptions were, how they relate to other questionnaires. They're not written down. They're in the brains of some people, but not usually written down anywhere that we can mine. Not even ChatGPT can mine it. And the relationship between the terms and the symptoms, not there. Basically, it's all text, no objects. And then reuse and adaptation of these documents, well, they're prone to errors, but it's also like really super common. Everybody wants to put their little stamp on it. So you've got this ad hoc creation of all these derived questionnaires, and they don't usually tell you what they're derived from. There's shortening of items, there's combination of items, and so it also might lead to incorrect or inaccurate diagnoses. And there actually is, the good news is he, and now we, have kind of a success disaster, because there's increased interest in widespread adoption of these measures in mental health. And actually, this was even before COVID, and this was before, and I think, I don't have the data to support this, but I think we all could do a search quickly and find out that mental health is just more of a problem than it used to be, given that we've been in isolation and we had this pandemic. So we want to support measurements across a lot of contexts. So we started with this, the semantics of the RCADS questionnaire items. And so we have a growing, freely available ontology of the questionnaire items. And actually, we built this, we were kind of the dream team for this, because in a larger NIEHS funded National Institute of Environmental Health Science, my group, along with a bunch of epidemiologists and toxicologists, have a large project on exposure and health. It started with exposure and child health. So if your mother was exposed to heavy metals and the child had delayed cognitive development, this was not uncommon. So my team has the data science core of that. So the ontology for all of exposure science and all of health outcomes, just a tiny job doing that ontology. But in that, there's a whole, because epidemiology is often based on these questionnaires. So in that, we've got a whole lot of questionnaires aimed at exposure and health. So we actually had, in many ways, kind of perfect experience to encode these questionnaires. And then we looked at the many different versions of RCADS and said, how are we going to encode this so we can see how the different versions of it are connected? And the most common two are the 47 question version and the 25 question version. And then, it's all encoded. Thanks to largely Enrique Santos, who was the first author on this, and Kelsey, who was the second author, the graduate student. But the whole team is involved in pretty much everything. And then it also is built on top of the Human Aware Science Ontology, HASCO, which actually also is behind these large data portals for exposure and health, and has had reuse in a growing number of scientific data portals that kind of meet all of those challenges of that beautiful picture of all those little zip drives and thumb drives. Yeah, this started with a project where we were working on water data from 40 years. So some of it wasn't even on drives. bankers boxes of pencil annotations on kind of these questionnaires on water samples over 40 years that somebody went out kind of in the middle of the lake, kind of that way, and took a sample, kind of at 25 feet deep. So it was aimed to capture the metadata in a scientifically valid way. And that's kind of where it started. So it's kind of expanded out. And then we add the psychometrics ontology. So, if you're going to measure, assess, and evaluate psychological issues, you do it in psychometrics. And we've got this growing ontology. Also, we're open to partnership. So we're now compatible with the RCADS version, the GAD, the general anxiety depression version, and a growing number of instruments. So we're building SIR, the semantic instrument ontology. And that's where I'm solving kind of the local problem for this, but it's on a step towards trying to help make a difference in telling people the evidence behind an intervention that's aligned with a particular disorder as measured by these questionnaires. So the SIR, the Semantic Instrument Repository, is an infrastructure that manages the knowledge graphs and the data acquisition of instruments. And it implements the semantic instrument, and it includes this canonical, what a surprise, RDF description of instrument and the building blocks. And it's being developed using kind of common tools, and we're FHIR compliant. And actually, when Bruce came to me, he said, the condition of giving you a subcontract is you have to do a FHIR server. And we're like, okay, we can do a FHIR server. So, be compatible with best practices and then make it open source and freely available. And it's available using kind of best practice tools. So we've got a Drupal service, a SIR API service compatible with FHIR, and has the canonical representation. And we solicit expansion requests, like all good, hopefully good, ontology owners and evolution support systems. So we're also connecting it with NHANES, so the National Health and Nutrition Examination Surveys. I got heavily involved with NHANES when I started working with epidemiologists conveniently before the pandemic. So I spoke epi before the pandemic, which was great. But they kind of live and breathe these questionnaires that I think this is the biggest collection of questionnaires, at least that made a difference for exposure and health. And there's a lot of common vocabulary there. So we're consistent with, actually, prior to Bruce's work, we were consistent with NHANES, and we've been slowly pulling in a lot of content from NHANES into a harmonized data repository, because trying to use the NHANES data, if you've never tried to use it, be prepared for a little bit of a learning curve. I mean, the good news is there's at least some documentation. But it's not so easy to just get up and get started. So we were trying to integrate that and have this harmonized repository that's also freely available. Two of the people on this project were born in Brazil and speak Brazilian Portuguese natively and have a lot of connections to Fiocruz, which is Brazil's basically the equivalent of NHANES, the National Health Surveys. And then we actually are also looking to connect it to some other surveys. So many countries have these national health surveys. Korea's got a good one, and we actually had somebody who was willing to do some translation work for us, because I don't want to depend just on Google Translate, despite the fact that it's pretty good. We really care about the relatively perfect, as perfect as I can get alignment. And these automated tools are a good first step, but they're not enough to count on, making health decisions that might make a difference in suicide prevention. And then, of course, we want to expand to include questionnaires beyond just mental health, actually beyond just anxiety and depression. But because Bruce is an expert, a really well-known expert in anxiety and depression and child anxiety and depression, that's where we're starting. So there's a lot of ongoing work. The Semantic Instrument Repository is being deployed at UCLA, which is where Bruce works, and which is where the home for like all of his questionnaires are overall. And that's soon, end of May, we're actually going to be up and running. The Psychometrics ontology is growing, and we welcome comments and reuse. We also have this hub, the Semantic Instrument Repository Hub, where we're putting in the instruments that we've encoded for this project, but also connecting it to the instruments from NHANES that make sense. Um, and actually, we're metadata people. So we collect and maintain, kind of an excessive, but I think most of the people in this room would realize that there's really no excess when you're collecting a lot of metadata, because metadata is gold for how to use it, what assumptions went into it. So we're kind of heavily annotating with that. And we're compatible with a lot of the World Wide Web Consortium standards, including the ActivityPub protocol. So the local problem of the instrument repository, we are solving. So we've got the semantically enabled repository for data acquisition instruments. We're focusing right now on the anxiety and depression scales, but we're expanding out. And we also support the authoring and reuse and distribution of these questionnaires, because poor Bruce, which is what he was complaining about. One of the things he was complaining about when he came to my office, he's like, everybody wants their own version. And and it needs to have a psychologist blessing it. And like Bruce, am the person who has to bless this stuff. And, he has this much funding, but, that needs this much funding. It's going from the prototype to the enterprise that, we were having a lot of discussions about this over the last portion of a day. That's where it's expensive. It's also tedious, but you need to be right. You're not, despite the fact that I love automated tools and semi-automated tools, they're good for a starting point, but they're not good enough to do the blessing part. And we're providing canonical representations. We're compatible with the human aware science ontology. The VSTOI was the instrument ontology for one of the very early virtual observatories, kind of historically named for the Virtual Solar Terrestrial Observatory that I worked with NCAR, the National Center for Atmospheric Research, on. But that instrument ontology that Peter Fox and I did about 20 years ago, it's lived on and expanded. We should probably get the ST, the solar terrestrial, out of the name, but it's a historic name. So it's really a virtual observatory instrument ontology that has seen a lot of reuse, and also this novel psychometrics ontology to attach semantics to the questionnaire, so you can know what changed about it, what it's derivative from, how it's connected to other instruments. And there's a growing amount of documentation at the hotattack.org site. So Hotattack is a human-aware data acquisition framework that is beneath a lot of our data portals. And it's partially funded by my organization, the Tetherless World Constellation at RPI, by the William T. Grant Foundation, and by the National Institute of Mental Health grant, and hopefully a few more grants. So with that, I would be super happy to take some questions. Thanks.
Well, this is super cool research, Deb. So I'm a psychologist, right? So I've for about 10 years ago, I tried to do something like this with psychological tests. And I got into such a mess with licensing, because every university has these tests and they never want to give it away. And if you give it away, with all these guards. So do you have a licensing scheme for this too, or is it just all public data sets?
Yeah, so Bruce went on and on for his challenges with trying to give away his RCAD stuff. And, UCLA, where he's a professor, had some rules, and NIH had some rules, and the William T. Grant Foundation had some rules. And, and then it got into this enormous mess, and nobody was willing to pay for it enough, which is where, actually, I don't have his company on this, and I've just forgotten the name of it. I'll figure it out later. So he did it through this company that hired some lawyers and got some licensing, so that it's licensed in at least the countries that have the 19 different versions. So they've worked through it for that, so that you can. Well, I have to defer to him, and he's not in the room, for the challenges and the hurdles that he's passed through. But um, a lot of countries, so the United States, and I think all of those countries that have translated to those 19 languages, demand that you use this. So organizations, I'm looking, I don't know where you are at NIH, um, but NIH, at least a portion of NIH, demands that you use the scale if you're going to do work on child anxiety and depression.
Okay, and one more question. So, I mean, nothing in psychology is certain, right? So, is there any component of probability and certainty or uncertainty in here? Because I thought this causes this. Well, forget about it, right? I mean, this might cause this, or this combination might be indicative of, but you
Yeah,
can never
so
say this causes this. That's
I don't think we've got the annotations at the level that I would like to see them. But they do point to the documents. Like I'm steeped in another project. I'm steeped in clinical practice guidelines where, you know, a particular recommendation is grounded in these 10 studies, and then there's a pointer to those studies. Um, they've done that research, and I don't think all of that is fully annotated, but there's a few psychologists, maybe more, maybe we should get you, although in your copious free time, which doesn't exist. They've poured through a lot of these studies to annotate which study was used to say that it's indicative. You know, we probably shouldn't have had the word probability there. We should have used the word indicative. And they have validated those scales against diagnoses, you know, in small segments of the population to show that the scales actually hold up. It's a pretty old scale. I should know how long he's been using this scale, but it's been around, I want to say, at least a decade.
anyway. Thanks.
Yeah.
Very cool research.
I have 2 minutes and 50 seconds.
Yeah, thank you. This is very cool. I wonder if you have considering the next step, extending this research on studying like suicide, because like, for example, there are also many of the national-wide surveys that has suicidal ideation plan attempt data, and now especially youth suicide is an important issue that we want to study. I'm studying suicide research and how it links it to using machine learning and predicting and surveillance. So I think this could be a very cool tool. And like, for example, the national like youth risk behavior survey, it has one. The NASDAQ, the drug use and health survey has one. I wonder that if they can be linked it, and some of them already also screening is screening depression and anxiety as well. What do you think it can be linked it? Whether there is a possibility of extending the research in the next step?
Great question. The fact that they've already got these instruments to measure this, and the fact that they're, you know, it's not surprising that suicide is connected to anxiety and depression. You know, actually, the fact that we've got a computationally available encoding of the terms related to anxiety and depression from these scales, I think actually there could be a crosswalk. So we should be able to do that. Well, a community should be able to do that kind of linking, you know, and you probably could get a starting point with machine learning suggestions for the linking, but I would want, you know, somebody like you, some expert to actually bless those links. Our primary next step, actually, it's not on here, but our primary next step is to really get to the evidence-based recommendation for the intervention. This is just getting these instrument repository up and getting the linking of that, which I think we should have a conversation afterwards because
Yeah,
I
let's
think
have a conversation because we also collect data on that, and also we collect geospatial data about like, especially like YRBS. It has also exactly know which school is screening, and school-based interventions for preventing suicide is very important, as well as the community-based as well. Let's have a conversation. Thank
okay,
you.
cool.
Thanks, Deborah. And I
Okay.
think we've got a break now.
Great. Thanks very much.
Thank you.